So for the next section on today's program, we're going to shift gears a little bit and dive into the clinical perspective. We wanted to speak with practitioners who have already incorporated myopia management into their practice so that we can learn more what they face day in and day out. So first, I want to thank you all for taking time out of your busy schedules to join us today for this important discussion. To start things off, I'd like for each of you to briefly introduce yourselves, tell us a little bit about your practice, and then maybe state how long you've been actively managing myopia. I'm going to go in alphabetical order. Sorry, Dr. Zhu. So Dr. Chen, can you kick us off, please?
Sure. So hi, everyone. Thanks for having me, and thanks for taking time for joining this important event. So my name is Dr. Kevin Chen. I am the Senior Clinical Director at Healthegy. And Healthegy is actually the first and only private company solely dedicated for myopia management for children. And it was founded in 2016 by Dr. Gary Gerber and his partner, Matt Erding. And currently we have the flagship store in the office based in Washington, D.C. area. And recently we have been launching a lot of in-office Treehouse brand myopia service for other private practitioners. So recently we actually have hit our milestone to reach 40 offices in 17 states as of today. And I think this is a really great platform for private practitioner to participate in more in myopia management so that we can benefit more kids in the States.
And Kevin, how long have you been actively managing myopia?
Since inception, I have starting to practice about 7 years ago, but actively I have started managing myopia since I joined Healthegy in 2016, full time.
Okay. And Dr. Clark.
Hi, I'm Robert Clark. I'm actually in private practice in Long Beach, California. I'm also on the clinical faculty at the Jules Stein Eye Institute, UCLA. I've actually been doing myopia control since the early 2000s. I'm probably dating myself over here. Been really doing quite a bit over the last probably 8 to 10 years, more so than earlier, just because there's been a lot of scientific developments over the last 8 to 10 years.
Great. Thank you very much for joining us today. Dr. Ramsey?
All right, thanks for having me on here. I own Socialite Vision in Palm Beach Gardens, Florida, and it is a boutique optical that we do some medical management and eye diseases in my practice. I have been managing it seriously for the last 5 years. You know, we've all been seeing those patients, but I feel like the technology and the education has met up to where the practitioners are. And so the last 5 years, I have more actively been taking more control over myopia instead of letting it happen on its own. I've been making it happen the way I wanted it to.
Great. Thank you very much. And Dr. Richdale.
Hi, I'm an associate professor at the University of Houston College of Optometry. I would say I've been fitting orthokeratology lenses for about 20 years, but like the other people on the panel, I've probably been actively implementing a protocol to practice myopia control for the last maybe 5 to 7 years.
Great, thank you. And finally, last but not least, Dr. Zhu.
Hello, hi everybody. My name is Dr. Xiaoying Zhu. I'm a full-time faculty member at SUNY College of Optometry. I'm currently the director at the Myopia Control Clinic. Our clinic was actually founded in 2016 by Dr. Catherine Richdale, and I have been actively managing patients for myopia control for the last 5 years.
Great, thank you very much. So actually, let's stick with you. For my first question, can you tell us a little bit about what myopia management treatments you use in your practice?
Yeah, so we do all 4 pillars of myopia management. We do ortho-K, multifocal soft contact lenses, including MiSight, and low-dose atropine eye drops. And occasionally, for kids who cannot tolerate contact lenses or eye drops, we do bifocal glasses or progressive glasses.
Okay, great. And Dr. Chan, I know that you use multiple therapies in your practice as well. Can you tell us a little bit about the situations that you may choose one over the other when managing your patients?
Yeah, so I'm also doing a lot of ortho-K in combination with atropine and soft lenses. Depends on the clinical assessment and the risk factor combined. If a 6-year-old come in with high myo and both parents are being myopic, and I'll definitely be more proactive and aggressively in treating that kid versus someone coming in at 16 and no family history of myopia, and patient is not too motivated to start any contact lenses, I'll probably start this patient with atropine.
Great. Okay, thank you very much. So now we're going to take a little bit of a trip across the country, starting with the East Coast. So Dr. Ramsey, when parents or parents of your patients that come into the practice, do they generally come in asking about myopia, or is that something that you have to bring up to them?
Most of the patients do not know. They'll never use the term myopia for one, nearsightedness for the most part, and most of them just come in expecting glasses. And when I give them an option to say, "Hey, you were a -2 in your glasses, and now I'm refracting you at a -3. Would you like to do something about not turning into a -4?" That's when the conversation starts. But they rarely come in asking about it unless they've already been started on some treatment somewhere else, and then they get referred from another provider. But very rarely does somebody say, "I've been looking into ways to stop my kid's myopia." Like, I would love to get that parent. That'd be really easy, but that is almost never the case in my situation. Maybe somebody else has the golden situation somewhere else, but no, I'm having to bring that up and educate them that there's even an option. And I think that's where we're missing out on, is that parents don't know that there's an option. And parents know there's an option for teeth and dentists and braces, but it's not known that you can do anything about it. And I think that's the difference.
All right, great. And Dr. Richdale in Texas, is it any different here?
Well, I'll add to Dr. Ramsey and say I maybe have the golden ticket because I'm only practicing in the myopia control clinic now. So patients do come asking for myopia control. So I'm fortunate there. But I will say I've had the experience where parents have said things like, "My doctor didn't tell me about this before. And why didn't anybody tell me? Or I wish I would have known this." And right, it's kind of a tough area, but I think an important area to discuss, and not shaming other doctors or making the parents feel bad for not doing something earlier, that this really is a quickly evolving and changing area. So it's important, let's start now and move forward. I have those kind of conversations with parents, but they're all pretty familiar with myopia control.
Okay. And last on the West Coast, so Dr. Clark, you are, I believe, the only one on the panel that might practice in 2 different settings. Can you talk about what your experience is with this, with parents being educated about myopia or not?
Well, there's actually kind of almost 2 classes of parents that come in. Now, the parents themselves that are actually myopic are pretty aware of the different problems of being myopia. Sometimes they're asking for myopia control, especially if they're Asian in ethnicity. They have an awareness of orthokeratology and some other modalities as well. They may not know of all the more recent developments, but they have an idea here. The ones that are not, though, it's kind of like the population comes in there, they've been referred because they failed vision screening. "Oh, I'm a pediatric ophthalmologist. My population may skew a bit younger than some of the other populations that you might see." So I see kids as young as 2, 3, and 4 who fail photo screening. And for many of these parents, it's a shock. Number one, the kids need glasses. "Hey, little Joey's functioning fine." Well, yeah, he's not going to school. He's not trying to see the board, but actually he's already myopic. And at -3, -4, he's likely to become quite myopic before we're all done. And so there's a lot of education that goes on in that context. So there's really 2 populations: the ones that the parents are myopic, they're familiar with the ortho case and the older technologies and whatnot. That's probably a minority. The majority are kind of freshly diagnosed. They've never had glasses before, and now the numbers kind of are progressing, and maybe they're progressing over the last few years, and they're more interested.
Great, thank you. So I'm gonna move on a little bit. So Dr. Chan, you told us you have a very unique practice. I'm very interested in how COVID has how you believe it may have affected either myopia progression or parents being interested in myopia management. Can you talk a little bit about that?
Yeah, sure. So I think I'm like, everyone in the panel here, and we are all on the same boat suffering from, COVID, and definitely there's some tremendous impact for children's vision during this time frame, especially more and more kids are spending indoor time and lack of outdoor time as well. And parent also not really comfortable letting the kid go outside and play with their friends. As a result, it just make the snowball keep going up and exacerbate the progression. So as a result, I don't know if it's a blessing in disguise, but actually more and more parents actively asking me about what we can do. They don't use the term myopia, just like Dr. Ramsey said, but there's a lot of wave of or noises about talking about how can we improve my eyesight so that it won't get worse. That's in their terms. So I think we are trying to create more recognition. I think parents are starting to recognize these kind of changes could actually negatively impact on their eyesight.
Great. All right. And Dr. Zhu, I mean, you're in a very unique setting as well, being in the middle of the largest city in the United States. And I imagine that outdoor time is something that, kids might struggle to get to begin with, but with COVID, are you seeing any patterns with your patients?
Absolutely. So I have been seeing like definitely faster progression rates lately. Like last week, I saw a kid whose glasses prescription went up by a whole diopter within the last 3 months. Wow. So yeah, and we're definitely getting more and more new patients seeking myopia control, and the parents are definitely more interested in myopia control as well. And I'm not sure if you guys saw this, but Java Ophthalmology published a paper earlier this year, and the study included more than 100,000 children. And the study found a substantial increase in both myopia progression and myopia prevalence in children. So the change is really drastic.
Yeah, okay, it's concerning for sure. So Dr. Richdale, let's go back to the conversation that we had earlier about speaking with parents. So can you tell us how you talk to parents about nearsightedness or myopia?
Sure. We try to keep it pretty simple. And as I'm also teaching students and residents, we talk about using lay terminology and talking about what myopia is, that it's nearsightedness, why we think that it happens, both genetic and environmental causes, why we care, meaning that there could be an increase in risk of other complications like glaucoma or retinal detachment, and then follow up with what we can do. So we usually use an analogy such that, especially if the parent's myopic, right? When you were a child, you were just given stronger glasses, but now we know that there are treatments that we can use that can actually slow down the progression.
Great. I know that Dr. Tom Aller likes to use an analogy of a balloon when he's speaking about myopia and how it affects the eye in terms of stretching. But does anyone else have any clinical pearls that they would like to share about how they speak to parents about this?
Well, there's kind of almost two scenarios here. One is that if the parent already wears glasses and is myopic, those parents, once again, are much easier to explain because they've gone through it. Every year the glasses got stronger. You say, hey, the child grows, their eyes going to grow and elongate as well. Start young, you can slow that down here. And you talk about the environmental, but the other part is the parents that don't have strong glasses, and then they don't actually have an idea of just how bad it can get. And for there, I use the handheld lenses quite a bit. They say, last year your child's glasses were, -1. And this is what -1 looks like. Look around the room over here. You can see most things here. And then now it's -2. You got to project it, down the road. Here's -3 and so forth. And it gives the parents an idea of what their child's vision will evolve. Now, just as an aside, in terms of the whole COVID thing, California has recently been opening up. And it turns out that kids that were ensconced at home in front of their computers did not complain about their myopia. And now parents are seeing a really big jump up. I had one kid who walked in there with her -5 glasses. She was 2,200, and she would have 2.25 since May. But of course, she didn't complain about it because she's not going to school. She's just in front of her computer, happy as a clam. And so the parents were absolutely shocked. Now, she was a child who had actually been prescribed atropine, and they were sitting on her shelf, and she never took it. And so basically, now she's a 7.25 or 7.5, and that's a really big progression. But I think when places start opening up and people start sending their kids to school, they're going to realize they're going to do a lot of failing vision screening tests, even with their current correction in place.
You just mentioned this one patient who is already a high myope now. When you speak to parents, do you tend to talk about the health consequences associated with it? I'm just curious, how do those two different groups react? Either the ones who are myopic, but may not know about the health consequences, and the ones who are not myopic?
I think those are actually two very different conversations. I think for many parents, if you say that, hey, you might develop a cataract, you might develop glaucoma, you might develop problems with the retina many years down the road, it doesn't really have much of an impact. If you really show them how the visual function changes. And to me, one of the big things is if you show people what a moderate or high myopic lens does to the vision, it makes things small and distorted. So if you hold, I say, my two eyes are about the same size. If I hold a -3 or -4 in front of one eye, now that eye is much smaller. Well, guess what? In the real world, it's harder to see things that are smaller. And then if you throw in the final kicker, which is basically your child who's now 4 years old, already at -3.5, they may not qualify for laser surgery if we just let things go. It'll be too high of a number. They won't qualify. Then they really start to pay attention. It's different if you have constantly somebody who's 15, 16 years old and they're like, -2, -3. But I'm seeing more of the younger population. Once the parents realize, hey, it's not just a question of, hey, they can just have the laser surgery when they're older. Who cares? They'll be fine. That hey, the quality of vision is going to suffer. And when they're all done, they're not going to qualify for all these nice things. Then they pay more attention.
Dr. Ramsey, I'm curious about in your practice, do you tend to talk about health consequences and how do parents react to that?
Like Dr. Clark said, you can mention it, but it doesn't really hit home because what is glaucoma to a person that's never experienced it? What is a cataract to a 25-year-old mother? It doesn't hit there. What I tend to do, and this might be my little clinical pearl here, is I relate it to braces. And I say, these are the braces for the eye. And when you give it to in a term in which they understand teeth straightening, and then they understand needing a retainer to keep it consistent, then they're like, oh, okay. And then braces cost thousands of dollars. So then when you give them something that may cost $1,000 or $1,500, $2,000, then all of a sudden they're on par in understanding it. So dentists have done a great job. So I try to steal as much from them as I can. I think relating it to terms in which they understand is a lot better. The medical stuff, even if you show them pictures, that's a big hill to climb that it won't close the deal in my practice. You can mention it, it's information they should have, but would that get a parent without the other conversations? Would that get a parent to sign up for one of these treatments? I haven't seen it successful, but maybe some of these myopia management gurus can give a different opinion.
All right.
Joe, may I add something to that topic?
Yes, please.
I completely echo what Doctors Clark and Ramsey just mentioned. In my experience, I feel like if we spend too much time talking about the ocular consequences, it might actually put people off. And I've seen parents become very, very concerned during the conversation. You can see their face, like their facial expression just change. And our media people prohibited us from including the photos of eye sockets or like the fundus photos on our flyers because it tends to scare people who are not in this field. And I think it's better to focus on the positive aspects of myopia control, the benefits of myopia control. It's going to, hopefully it'll maintain your prescription stable and hopefully maintain your ocular health, and how exciting for kids to try contact lenses. And parents tend to respond better to that kind of conversation.
Makes sense. So let's stick with you for a second. So do you tend to present all myopia management options to parents, or do you tend to hone in on a single particular recommendation when you speak with them?
Yeah, I tend to do a combination of both. So at first we would have a conversation with the parents and patients to get their, their lifestyle, their hobbies and interests and so on, and what their expectations are. And I would start the conversation by telling them what treatment options, let's say Johnny would be a good candidate for. Let's say that Johnny would be good for atropine and contact lenses and all these things. And then based on Johnny's hobbies and interests, I will hone in on one particular treatment. And we have patients who are competitive swimmers who will travel across New York State, or used to travel across New York State for competition. So obviously, ortho-K would be the best treatment option for Johnny. So then I would hone in on that particular treatment. But I do want to present them with all the options so they can make an informed decision.
Great. Dr. Chan, do you have a similar practice?
Yeah, I agree with Dr. Su, and I think I usually start off the conversation by asking them lifestyle question, what kind of hobbies the kid had, and I'll start from there. If they are very athletic, very active, being outdoor, I'll definitely present options, for example, ortho-K and contact lens soft multifocal contacts. Whereas if a kid is rarely being outdoor and being a bookworm all the time, and I think they're more likely to be shy about contacts. Instead, I will be leaning towards atropine for those patients. But I definitely present a comprehensive picture for what kind of treatment modality can be suitable for this type of patient.
Okay, great. So Dr. Richdale, when you speak to parents about the options for their child, do they tend to decide right away, or do they usually need to kind of go home and talk this over with their spouse and consider and maybe even research the options more?
Yeah, so we have gone back and forth both at SUNY and here at the University of Houston of having a consultation visit that's specifically designed to talk about myopia and myopia control. And I personally really enjoy it, both because it is dedicated time to have that discussion, but also because I think it is important to end that with the saying, this is something that, you might want to go home and discuss as a family before you decide which treatment option is best for you. And I think that has had parents trust us in that they're able to go discuss it. Oftentimes they'll book that follow-up appointment right there. But even if they don't, they'll usually give us a call back or come back perhaps with some more questions before we decide on what is the initial treatment that we want to start with.
Great. Okay, thank you. And Dr. Clark, what's your experience with that?
I tend to, once again, probably showing my age of it, I started with a lot of atropine way back in the early 2000s. I tend to put almost everybody on low concentration atropine now. I think it's very well tolerated and it's an adjunct. And I tend to add things to that based on the child's preferences. So I would do somebody who was, say, younger, not ready for contact lenses. I'd set the patient the information here. And because there's so much information online now about atropine, I encourage them to go on the internet. I actually give them a link to our website. We have a page on myopia, nearsighted treatments and so forth over there. I also talk to them about behavior as well. Nothing gets you on the parent's side more than saying, hey, your kid needs to be outside an hour or two a day. Your kid needs to be farther from their screen, their bigger screen. The parents are all looking at you. They're nodding their head. They're pointing at, see, this is the doctor telling you this kind of things here. So then you become on the parent's side about these issues over here. And behavior modification is something that's pretty easy to encourage and already puts you kind of on the parent's side. They've been telling their kids the same kind of thing. And then from there, you look at the kids' overall hygiene. You look at how easy they are to administer drops in the office for a dilated exam, whatnot here. You can make a decision about the contact lenses. And so for me, I tend to use contact lenses. It's not necessarily the primary therapy for almost anybody, but as something that you would consider, especially somebody's already using contact lenses, it's an easy conversion to a myopia control product. But if they're not, then I tend to start them on atropine initially. In my experience as well, there's like two groups of parents. The ones who are more familiar, the ones who are myopic themselves, you send out the same day. You send out the prescription, they're ready to go. The ones that are not, the ones that are low myopes or no myopes, they want to do some research. But almost all of them call back in a day or two. I give them our number, they have an email and text address. They just say, hey, just go ahead and send in the drops or start those. So it's a pretty high conversion rate for the eye drops to be started.
And let's stick with atropine for a second. So I know that you've published an article on the use of atropine, and we are expecting more options in the United States in terms of innovative formulations and delivery methods of atropine. Can you just say how you think these might help you in practice?
The biggest thing, and this is one of the things I've discovered with the MiSight being FDA approved, is FDA approval means a lot to the patients. If you have to give them more barriers to entry, you can't just go down to the Walgreens or the Rite Aid, it has to go to a compounding pharmacy. It's also level, anything that has more barriers to entry, it makes a big difference. Now, the other part is that sometimes the compounding pharmacies do have some variability in the amount of stinging on drop administration. And nothing turns off a child more than stinging. Turns out the parents as well over here. And I do know that they're working on some formulations that are preservative-free, formulations that are actually better tolerated. And so basically, if you could write somebody just a script to go down to the pharmacy, it's going to make a big, big impact. That's going to change the conversation entirely here. Now, in my looking ahead here, one of the downsides of the products I think that are in the pipeline are the latest research suggests a stronger concentration of atropine may be more efficacious than just the 0.01 that's been used now for quite a while. In my practice, I probably have about 80, 85% still on 0.01, but I have about 15 or 20% that are taking a stronger concentration. And so it'd be interesting to see whether or not those products will still have to be available on a compounded basis, or whether or not they'll continue to extend the market and have kind of a bigger variety of strengths. You start them on a starter dose, kind of like with the braces analogy, you have to use a little bit more strength to achieve the control that you want.
For the 20% in your practice who are not on 0.01%, what percentage do you use with them?
2/3 are on 0.02 and 1/3 are on 0.03.
Okay.
Now I'm in Southern California. I rarely go above 0.03. I know the studies suggest there's very little pupillary dilation. That's not my experience at all. Once you get above 0.03, there's a significant number that have some light sensitivity. Not only that, but I think there's a bit of a threshold effect. In other words, if a kid is going to respond to atropine, you'll start to see a pretty good effect by 0.03, or they're not going to respond. And so you find yourself keep on increasing it. When I was first started doing this, 15 years ago, I used to go up, 10 years ago, up to 0.05, 0.1, but I found that those kids continue to progress. And so here's where the other modalities play a role. So you'd go to 0.03 pretty consistently. At 0.03, if that's not working, you want to switch modalities or augment your modalities, add a different modality.
Great, thank you very much. Dr. Ramsey, back to you. So you mentioned that you have a boutique optical. So we are also expecting eventually to have some FDA cleared spectacles on the market for managing myopia. I'm just interested in your thoughts on how you might see those playing a role in practice.
That's a game changer. That's the golden ticket to make this go like wildfire, because there are parents that don't want to put in any medication or drugs in their kids as much as possible. And then there are people that are opposed to the contacts. So, and then the line bifocals that you have cosmetically, not very appealing. Kids got on braces and line bifocals, not going to be the most popular kid in school. So, especially with my practice, most of the people on the panel here are in a particular myopia control place. So they're coming in for that. That's not my office. They're coming in, my kid, I'm on their insurance, and they're coming in and I'm having that conversation. I'm having to be the first one to talk to them. So if I could prescribe something that wouldn't have to change their behavior at all, they just get to do what they were expecting to do, the likelihood of me getting almost all my kids in some form of myopia control goes up exponentially. So I would definitely say that is the golden ticket that's really going to be missing, and just waiting to see if it's effective. And if we can get something that is effective, cosmetically looks good, and it can work for the patients, that is the golden ticket. It won't take away from any of the other modalities. There's still a place for everything else. But you're talking about half the patients that you want to put into something that may say no to the other modalities, that then would be open to something along these lines. So in my optical, that would definitely be something that would be a game changer, and it's what everybody is sitting here waiting on.
Great, thank you. I'm going to switch gears a little bit again. So, Dr. Chan, we have a number of industry colleagues who are tuning into the program today. My question for you is, what resources would you like to see them provide you to have in practice to either help parents decide or to just help you manage myopia in general?
Sure. In our office, we typically train all the staff members to be acquainted and familiar with, what kind of verbiage we want to deliver for those parent. And we typically also deliver the AOA and the World Health Organization mission statement especially about myopia care. We recently have heard about good news that myopia care could be considered as a standard of care in the near future. So it's a unanimous vote by the World Health Council. So it's definitely a cheer for us. And at the same time, I also want typically start up with a simple questionnaire, try to gauge about age, refractive error, family history for the risk assessment. And that will actually give us a heads up how to treat this patient. And for those parents who are more, they want more visual information, I will typically use the Brian Holden Vision Institute calculator to kind of estimate what kind of projected myopia progression it would take.
Great. And when you talk about kind of this questionnaire that you'd like to see, is that something that you want to be online so that parents can do that ahead of time, or what type of format would you like to see that be in?
Yeah, we typically provide those prospective parent online questionnaire to fill out before they come in for the initial consultation. That way we will have a starting point to know how to gauge the conversation. And it's pretty easy. And, there's some resources from the myopiaprofile.com. It's also a really good resource for those ECP who want to start with myopia management.
Great, thank you. Dr. Ritchie, I'm going to throw it over to you. So for the industry colleagues that are on today's program, do you have any, requests from them of things you'd like to see?
I do. I don't know if this is a legal request, but they've already started to do it, in that we see a very much uninsured, underinsured population who have a hard time, being able to pay for the basic necessities in life for their children. And so the programs that these companies are putting out to be able to provide myopia control for these kids who couldn't otherwise afford it, I would love to see an expansion of that. So any child who is myopic could have a chance to receive these treatments.
Great, thank you. Yeah, I think that's very important. Dr. Zhu, same question. Any requests that you have from industry for things that can help you?
I completely agree with Dr. Richard just said. In New York City, there's a large community that's underserved. And I can't tell you how many patients I've seen who are in dire need for myopia control, whose parents cannot afford it. And especially because of COVID, a lot of parents become unemployed. So now the situation is even worse. So I'm hoping that the companies who provide us with these great products can also provide some kind of financial support for these families.
Great. Okay, thank you. There's a lot of talk about whether or not you need to measure axial length to manage myopia. So I'm just going to do kind of a rapid fire one on this one. I'd like to hear from all of you about whether or not you think you need to measure it and continue to monitor axial length. So Dr. Clark, what's your thoughts on that?
I do not routinely measure axial lengths. I think that's more of a research tool, and all of the modalities appear to reduce the progression of axial length. Now, parents are very data driven, and most of them will write down their prescription each visit, and they'll jot it down on their phone, things like that over here. You give them a number to monitor, they'll monitor that as well. But the question is, which is more important to them? Right? It's more important to them that their child's glasses or contact lens prescription is not getting thicker and stronger versus, hey, it went from 23.18 to 23.22. They don't have any idea, any context how to put that in.
Okay, great. Dr. Chan, same question, axial length or not?
In my perspective, I think axial length would be a really good indicator for trying to keep track of how your treatment progress look like, but it shouldn't be the impeding factor for other ECP to pursue myopia management. because especially, with, the new innovation about spectacle for myopia management, it definitely will widen the accessibility for other ECP to, get started with myopia management. So to answer the question about axial length, it's definitely strongly recommended, but it shouldn't be the required factors.
Great. Okay, Dr. Ramsey, in your practice, do you measure axial length?
I do agree that it is important in myopia management, but I don't agree that if you can't measure axial length, you shouldn't do anything. You know what I mean? If you can do something, it helps. If your practice can grow to afford to add in axial length measurement and add that in to your protocol while you're seeing these patients, then go for it. But I would never want to wag my finger at a practitioner that doesn't do axial length and say, if you're not going to do that, then don't offer anything and refer them to me. Well, that's not happening. They're not referring them to you. They're not going to lose that -2 patient. So let's start from a place of being fair. I would rather see a practitioner do something and grow that practice and see it go. And then we get an affordable cost of axial length, because the issue is the cost to measure axial length is very high for something that is not reimbursable. So if these companies can come out with something that's more affordable, it is much easier to say, let's add this into the practice. But for something that is $30,000 sometimes, that is really a big hill to climb for somebody to add that into their practice, into their protocol. So I think instead of telling the practitioners they should add it in, let's talk to industry and say, hey guys, you guys need to get more creative on a way to get something affordable so that more practices can afford to add it in. And then we can make that more of the standard of care. It's kind of like when visual fields was the standard of care and OCT wasn't. We all knew OCTs were important and it was good, but we didn't make it standard of care until there was a way that it was accessible to more practitioners. And now it became a standard of care, but we didn't look down on doctors in 2010 saying if you didn't have an OCT, you couldn't manage glaucoma. So I think we just need to be more fair to the practitioners.
Great. No, thank you. And okay, so now over to the two 100% academics on the line today. So I know both of you have ocular biometers in your practice. Can you tell us about how you incorporate or not axial length measurements in your myopia management practices? Dr. Richdale, do you want to start?
Sure. So I agree with the rest of the panel. I don't think it's necessary, but I will say I think it's helpful. And I found it interesting to see how sometimes axial length will grow more in one eye than the other, or more than I expected based on the refractive shift. It helps me too, the autorefractor, right? There's noise in that measurement, subjective refraction, there's noise. It just, again, perhaps because I do have a research background, I like the extra information I have to help make a decision and educate parents. And I do talk to parents about it. We do know that your axial length is correlated with your risk of visual impairment. And so I do take the time to educate parents on what that number is and why I care. Because I think, again, that does ingrain them or keep them connected with why they are coming to our practice over another practice. So it's a little bit of a potential practice management tool as well.
Okay. And Dr. Zhu?
Yeah, we do axial length measurements every 6 months when we see patients. And every time when we see patients for like an eval, we issue a patient report on which we write down the prescription and the axial length at the current visit and the changes from the previous visit 6 months ago. And I think having axial length, having the data, it gives the parents some information that's tangible so they can really appreciate the effect of myopia control. And also I have seen physiological axial elongation without any change in the patient's prescription. So if you don't do axial length measurements, if you just look at the prescription, then you would have no idea how much the eyes have elongated and whether you need to modify myopia treatment modality at all. So from that regard, I don't think it's necessary or important at least to measure axial length. I do understand that it's very important to get a biometer these days. And I wonder for private practitioners, if you don't have one in your practice, can you find one in your community that you can share with other providers? So then still the patient can have that piece of the puzzle.
I love the diversity of thought on that question. So We're about out of time. I just have one more question. Maybe we have time for 2 answers for it. But Dr. Clark, you've been doing this for quite a while. Do you have any advice for your colleagues, your ophthalmology colleagues who are watching, who may not have started managing myopia yet?
I think that the pediatric ophthalmologist needs to take a bigger role in advocating for myopia management because we're the ones who are seeing the youngest patients. So typically, if a child fails their photo screening, they fail even for their pre-verbal or early verbal, they're not going to go to the local eye doctor, they're going to go to somebody who's a pediatrician knows over here. And so you should become very familiar with it. Now, you may not want to get involved, but there's actually more counseling and more time involved. I've trained somebody in my staff to do a lot of that counseling for me. So I take a lot of clinician time, but you would have an association, somebody who's nearby that you trust, that you can work with. And almost like the adult doctors do the LASIK referrals and so forth, or you could do a myopia management referral saying, hey, this kiddo really does need some help. They should be able to use your expertise. My practice is pretty full of patients who have cross-eyed problems and cataracts, but I really want this child to have the benefit of these services over here. And so becoming educated.
That's great, thank you. And Dr. Ramsey, for your optometry colleagues who may not have started managing myopia yet, do you have any advice for them?
It's a big deal. It makes a huge impact in patients' lives. And I think we don't realize how important and how powerful it is to make a difference and a change in somebody's expectation that it always goes up and it always gets worse. And my kids' eyes are gonna be like mine when they get older. And to see the lifestyle changes that they can make, the ability to see the clock at night, be able to get around and walk around without having to put on your glasses, and we've made a big difference. It can be done. You can take small steps. It is not a big hill to climb to get started, to make an impact, to make a difference, to give the patients the options, because we know better now. You have the options. The information and education wasn't really as readily available 5-10 years ago, right? But you can't say that anymore. It's there. So the fact that you're not offering it that's the issue. You should educate yourself. We all need to educate ourselves. We all need to take it seriously, and we all need to give the patients the option and allow them to choose. There are so many low entry point options, i.e. the atropine, the line bifocals, and the soft contacts that we all could do. There's not really an excuse for not offering it. So educate yourself, take the time, and it's a practice builder, and it's a patient enhancer. So go for it.
Great, thank you very much. So I just would like to once again thank this amazing panel of practitioners for their time today. It may sometimes seem like what you do in practice is routine, but I can assure you that all of us have learned a lot from what you shared with us today. So thank you very much. Next, I'd like to introduce Dr. Dwight Ackerman, who is the Chief Medical Editor of Review of Myopia Management and an International Myopia Institute Ambassador. Dwight's going to be moderating the next panel so that we can hear from our industry partners. So Dwight?